Okay, our next speaker is Guo Yuanyuan from the first affiliated hospital of Anhui Medical University. Her topic will be therapeutic efficacy and neural mechanisms of tACS in depression with suicidal ideation. Welcome.
Thank you. Many thanks to Professor Yan and Naomi. Good afternoon, everyone. It's my great honor to be here today, and I'm excited to present our study titled Therapeutic Efficacy and Neural Mechanisms of tACS in Depression with Suicidal Ideation. Depression, as we know, is one of the most prevalent mood disorders and a leading cause of disability, affecting more than 350 million people worldwide. Beyond persistent sadness and anxiety, it also interferes concentration, disrupts sleep and appetite, and in its most severe form can lead to suicide. Speaking of suicide globally, more than 700,000 people die due to suicide each year. That's one person every 40 seconds. And around 57% of these tragedies happen in those suffering from depression. Importantly, suicide ideation often precedes attempts. So early intervention at the ideation is crucial. With that in mind, let's review the current treatment options for depression. First, antidepressant medications are widely used, but they often take weeks to work, help only about half of patients, and may initially increase the risk of suicide. Then there's electroconvulsive therapy, or ECT. Highly effective, yes, but it requires general anesthesia and often causes cognitive side effects. That's why we are increasingly focusing on the non-invasive neurostimulation techniques like transcranial electrical stimulation or transcranial magnetic stimulation, which offer greater targeting precision and tolerability. Among these, transcranial alternating current stimulation, or tACS, stands out. It delivers sinusoidal currents that rhythmically modulate neuron activity, helping to regulate endogenous brain oscillations. As an emerging therapy, tACS may alleviate clinical symptoms by synchronizing neural rhythms, inducing neuroplastic changes, and regulating neurotransmitters like serotonin. However, not all tACS are equally effective. Two parameters are critical: the stimulation target and the stimulation frequency. Our choice of stimulation target was guided by the neural circuitry of SI. First, negative emotional bias, a precursor to SI, is linked to hyperactivation of limbic regions, such as the hippocampus and amygdala. Moreover, impaired risk decision-making, which sustains SI, is associated with dysfunction in prefrontal regions, particularly the dorsolateral prefrontal cortex, or DLPFC. Together, this DLPFC-limbic circuit may appear to underline suicidal ideation. Supporting this, our earlier work found that SI patients show stronger functional connectivity between the left DLPFC and the right hippocampus compared to those without ideation and healthy controls. And interestingly, this hyperconnectivity could be normalized by ECT. These findings strongly suggest that the DLPFC is a promising intervention target for SI. When it comes to frequency, we targeted the alpha band because it plays a key role in emotion regulation. Both our data and other studies have shown that higher alpha power correlates with greater SI severity. Therefore, we hypothesized that modulating alpha oscillations could alleviate suicidal ideation. We then conducted a randomized sham-controlled clinical trial in depressive patients with suicidal ideation. At baseline, all patients underwent neuropsychological assessments and EEG recordings. They were subsequently randomized to receive 1 week of tACS, 30-minute sessions twice daily, either active or sham. After treatment, we repeated all assessments. Our stimulation target was F3 over the left DLPFC. The frequency was set to the participant's individual alpha frequency, with the current intensity set at 2 milliamps. Finally, we employed a high-definition tACS montage with 1 central electrode surrounded by 4 return electrodes to maximize focality and minimize side effects. In total, 43 patients completed the protocol, 22 in the active group and 21 in the sham group, with no significant differences in baseline demographics or clinical characteristics. Turning to our primary outcomes, the figure shows red bars for the active group and the blue bars for the sham group. Suicide ideation was assessed using 2 widely accepted scales, the Big Scale for suicidal ideation and the Columbia Suicide Severity Rating Scale. Compared to sham, active tACS is significantly reduced both suicide ideation and risk. As for secondary outcomes, active tACS demonstrates significant improvement in depressive symptoms in SI patients. Interestingly, tACS also significantly enhanced the ability in risk decision-making. Patients were more likely to choose safe options over high-risk ones after active stimulation. And we all know bad risk choices can fit into suicide thoughts. And importantly, no serious adverse effects occurred during the treatment. Now let's move on to neural mechanisms. EEG analysis revealed that active tACS significantly reduced alpha power, and the magnitude of this reduction was associated with improvements in suicidal ideation scores. Moreover, we also found that tACS significantly decreased alpha band functional connectivity and increased frontal alpha asymmetry. In summary, our findings demonstrate that individualized alpha frequency HD-tACS targeting the left DLPFC can significantly alleviate suicidal ideation. We also observed enhanced ability in risk decision-making, a factor implicated in the development of suicidal ideation. Moreover, tACS significantly reduced alpha band power, suggesting this modulation may underline its therapeutic effects. Altogether, these results indicate that tACS is a safe and well-tolerated neuromodulation approach for alleviating suicidal ideation and potentially preventing suicide. I have no disclosures. Finally, thanks to my team, Professor Tian and Professor Wang, and my poster number is 15. Please swing by and chat with me tomorrow. That concludes my presentation. Thank you very much for your attention. Thank you.
Okay, thank you very much for your nice talk. So I have a question that you have 4 electrodes to do the tACS, right?
Yeah, 5, actually 5, just 1 central electrode and 4 surrounded return electrodes.
Yeah, so your target is DLPFC, right?
Yeah, it's the
so for the
central.
DLPFC, did you do some, like Dr. C did do some individual targeting calculation to calculate a target and place the electrodes?
No.
No, so you just, because DLPFC is huge, right?
Yes.
So which part of DLPFC will you place?
Just use the F3 is electrode, yeah, EEG used.
Okay. Yeah, probably you can communicate with Dr. C because she said the Brisbane cohort is much better because use the individual targeting, and the Melbourne cohort is using F3 beam.
Yeah.
So probably you can talk with each other, maybe in the future can enhance.
Okay.
And also talk to our lab because we also doing some individual.
Okay, thank you.
Okay, thank you. So.